good morning. Thank you for the organizing party. So today we have an interesting speaker and topic. First of all, let me introduce myself. I'm Chong Guan. I'm from Department of Psychological Medicine. I'm the moderator for the first session of today, Breakfast UMHealth Talk. And with me is our speaker today, Dr. Amarpreet. She is our senior lecturer in our department. She is taking care of our liaison unit in our department. The topic today, Dr. Amarpreet is going to share with us is on something quite critical in psychiatry setting, clinical setting. It's about how to handle cases with depression, with suicidal ideation, with one of the very novel intervention, which we call esketamine spray. So it's quite difficult to handle cases with suicidal ideation other than admission. In the past, we need to proceed with electroconvulsive therapy for this group of patients. Now with the available of new innovative treatment, it offers us another option to help us with cases with this type of complaint. Without further ado, I will pass the floor to Dr. Amarpreet.
Okay, thank you, Prof. Ang. Good morning, everyone. I will share my screen. Okay, so just an introduction first about depression and how prevalent it is in our country. As you can see here, we only have 1.3 psychiatrists for every 100,000 persons. The WHO recommendation is 1 to every 10,000. So we are quite lacking in psychiatrists. And then when you look at prevalence of depressive disorder, it's 3.8%. And treatment-resistant depression, 1.3. And the suicide rate is 6.2 per 100,000. So that's quite high when you compare to some other countries in Asia. So just a quick brief about what causes depression. It is caused by a combination of genetic, biological, and environment, as well as psychological factors. Of course, it can happen in any age. And it is now recognized also quite commonly occurring in children and adolescents as well, although they may present differently. In older people, they also can present with irritability, so you need to be vigilant about the signs. So anyone can get depression. Quickly, just overview on the diagnostic criteria for depression. Obviously, you have to have depressed mood. That's the first criteria, coupled with a lack of interest, or what we say anhedonia, which is lack of pleasure in activities. And then you have sleep disturbances. You may have appetite reduction or increase. Again, psychomotor agitation or retardation. And then you have problems with your energy, feelings of guilt, difficulty in concentrating, and of course, the most high risk symptom would be suicidal thoughts. Just an overview of the terminology. When we say suicide, what we mean is death caused by self-directed injurious behavior with any intent to die as a result of the behavior. Okay, so an attempt would be a non-fatal, self-directed injurious behavior. The intent is to die. So a suicide attempt may or may not result in an injury. Suicidal ideation is always confused with attempt and suicide. These are thoughts about wanting to be dead or active thoughts about killing oneself, okay? And then suicide behavior encompasses suicide, the attempts, other behaviors, and the acts that one does to prepare themselves. So let's talk about the drug that we are talking about today, the treatment, the new treatment. Typically, depression, even in the more severe cases, can be treated. So the earlier that you treat it, the better the outcome is. So this is what we have traditionally done. This is an overview of the treatment. Firstly, you can start off with medication, which includes antidepressant or other types of medication here. That's the first line usually. And this is usually coupled with psychotherapy. So there are many forms of psychotherapy, CBT, interpersonal therapy, personal therapy. These are talking therapies that you can use together with medication. That's probably the gold standard at the moment. And when things get a little bit difficult and patients are resistant or they have other factors that make the diagnosis complicated, you may use ECT or RTMS, and then you also may use other medications, other antipsychotics, and other types of medications like mood stabilizers, and we have also used ketamine. And then you have beyond therapy, which is exercise, sleep, healthy diet, stress management, and all these things are good for people even without depression. So these things should continue as per normal. So when we talk about depression, we always talk about the monoamine theory. Okay, so this says that this is based on the fact that there are multiple options for medication. However, they all kind of have the same approach. So what the antidepressants do is that they increase the action of the availability of monoamines at the synaptic level so that the symptoms of depression may be reduced. However, antidepressants typically take 4 to 6 weeks, so it can take quite a long time before it starts taking effect. So for the last 30 years, this has been our model. And more recently, there has been a shift in the emphasis from this model to the glutamatergic neurotransmission, because we know that glutamate is a major excitatory neurotransmitter, and this maintains the synaptic connections and plasticity. And then research has also showed that impaired plasticity may lead to loss of synaptic connections in patients with depression. So we're trying to increase that. So this, as you can see, this diagram, this is the normal way how monoamine neurotransmitters work in the synaptic cleft. There's a healthy amount of neurotransmitter here. And this is the presynaptic, postsynaptic receptor neuron. You can see that. And in depression, you can see that these things are greatly reduced. So we look here at the GABA receptor and then the NMDA receptor, which is on GABA. This is in an inhibitory neuron. This is in a healthy cell. You can see the synaptic density is there. And this causes the BDNF release and a lot of synaptic proteins here. So it causes this cascade, which is normal. In somebody who is depressed, this is greatly reduced, the glutamate. So this causes low BDNF signaling. And then you can see that the synaptic density also is reduced. So there's a growing body of evidence here that points to altered glutamate signaling in the pathophysiology of major depression. Now, the drug that we are talking about today, that the mode of treatment is called esketamine. So how this works is that it binds to the NMDA receptor on GABA. So it's like it's taking off the brakes and it's making more glutamate in the cleft so that you get more BDNF release and more synaptic proteins, therefore increasing the synaptic density. Okay, this surge in glutamate leads to increased AMPA receptor stimulation and then increases BDNF, and then you can restore the synaptic function. So this is how it is thought to be working. So the individual synaptic connections are constantly being remodeled as a result of experience, emotional processing, learning, memory, stress. It's happening all the time, okay? This process is called synaptic plasticity, and it means that synapses strengthen and weaken over time as a result of their activity. So in patients with major depression, you can see there's a loss of synaptic connections. So let's look at the study. This may get a little bit technical. So there are two studies here. One study was done initially called Transform 1, 2, and 3. This was looking at treatment-resistant depression. And then there's another one where they took patients with depression with current suicidal ideation with intent. And this is called Aspire. And then they followed them up in sustained study, which I believe carried on for about 5 years. So double-blind, randomized, placebo-controlled, multi-center phase 3 studies, okay? What they did is they took, as you can see in the Aspire, this is for patients with depression with suicidal intent. They took 456 patients with depression and suicidal intent. They randomized them to two groups. One was placebo with the normal standard of care, and then the other one was using esketamine 84 milligrams plus the standard of care. And then they followed them up in the Aspire trial. So this is, I believe, the first trial in the world to get an FDA approval to include suicidal patients. So it's actually quite controversial where a study would include this kind of patients. Usually in psychiatry, when you read the research, they always include suicidal patients. So this is the first FDA approved. So what they did was they screened for this 456 patients, and then they randomized them. They were in an inpatient psychiatric unit where they could be monitored, and then they were followed up to 90 days in an outpatient psychiatric setting. So these are the results, short-term results. As you can see, this is the Madras score, that measures the depression. It's a depression scale, and it dropped quite significantly, meaning it's good. A negative number is good. So it dropped quite significantly, about 15 points to 20 points, just in the first few days of treatment. So you can see a greater improvement when you are using esketamine and the standard care. And the changes were seen within 24 hours, starting at 4 hours. Another graph here to show the same thing. However, they also looked at from day 28 to 90 to show that the results were good. So the score dropped round about to 25, by 25 points. So that's quite significant. This is another thing. Aspire 1 and 2, I think one was European and the other one was in Asian setting, to show the same thing, that it doesn't really matter ethnicity, that you still get a significant drop in the Madras score. This is to show the remission rates over time. And as you can see, as time went on, the remission rates increased. Remission is a Madras square less or the same as 12, so that's quite significant. So talking about a new treatment, we also have to talk about some of the adverse events. So notably, the adverse events we're talking about here that is of concern probably would be the blood pressure, a feeling of dissociation and sedation. So we'll go through that a little bit. These are the most frequently reported events. Dissociation means where someone believes that they are not real, or maybe they feel that they are out of their body. You know, some people say they can see themselves lying down. It's a feeling of sort of unreal. So that was reported quite a lot at 26.1%. And as you can see, the other more notable ones would be nausea, vertigo, dysgeusia, dizziness, and then blood pressure increase was 9.6%. The dissociation intensity, however, decreased with repeated dosing, as you can see here. This is the CADS score to measure dissociative symptoms. So it started off at treatment, and usually it peaks at 40 minutes, and then it drops down again at 90. But then with each repeated dosing, you can see that the score drops, meaning that there is less dissociation. So that's a good thing. And this is day 1, day 4, day 8. When you are treating somebody with depression with esketamine, typically you want to start off twice a week. So you can see that the score drops quite nicely. And this is looking at the blood pressure, where there's a rise in systolic blood pressure and diastolic blood pressure here. But again, it follows the same trend where it increases and reaches its maximum value at about 40 minutes. And then usually it returns to pre-dose range by 90 minutes. This is the cutoff points where you would probably not administer the medication, and you would repeat the blood pressure and continue monitoring. Okay, in adults, it is if your systolic blood pressure is more than 140, and in older adults, it's more than 150. So blood pressure should be monitored after esketamine nasal spray administration. And then you want to monitor it at around 40 because that's when it peaks. And then you continue monitoring until it drops. Obviously, if there's an emergency, you would refer appropriately. And talking about sedation, it's the same thing. Also peaks and resolves around 90 minutes. And you can see it is dose dependent in those less than 65 years and then more than 65 years old. So how would you administer this spray? A little picture here. It's a nasal spray. Tilt the head to 45 degrees and spray one spray in each nostril. Okay, that's for the 28 milligrams. It comes in 28 milligrams. And for major depression with suicidal ideation, you want to start with 3 of those, administered twice a week. Okay. So if you're treating adults with treatment-resistant major depressive disorder, you want to start off with 56 milligrams. If you're treating them with acute suicidal ideation, you probably want to go higher at 84 milligrams. In subsequent doses with the suicidal ideation, you may remain at 84 if there are no major adverse events, or you can drop it down to 56. So it depends on tolerability. And what's recommended is dosing twice a week for at least the first 4 weeks. And then after your 4-week treatment, the evidence should be evaluated to determine whether you need to continue treatment or not. You may want to continue in a maintenance phase. That's up to the clinician. Right, little bit about this. Previously, we have used ketamine to treat MDD. However, esketamine has a very low first pass effect, which means that it's rapidly absorbed and it has a higher NMDA receptor. So it allows for smaller dosing and, smaller volumes, meaning less side effects. So it's an invasive way to deliver the medication, easy to use, and it's well tolerated. Okay, I believe that was my last slide.
Thanks, Dr. Preet. So thanks for the very informative sharing about this new product. Now we open up to the floor. We have about 7 minutes. Anyone have any questions or doubt about this product? You can put your questions in the chat box. Just a summary. So we found that not all patients will be responding to our conventional antidepressant when it comes to the treatment of major depressive disorder. Sometimes it's quite critical if their condition worsen and develop suicidal ideation. So we are venturing into different mode of action rather than just purely increasing the neurotransmitter, namely the monoamine serotonin, which we found that some patients do not respond, and we need this kind of different pathway type of antidepressant. So from my personal experience, the successful rate is quite high when you come to the use of esketamine. Okay, there's a question from a participant named David. So he asked, apparently in the psilocybin trial, they combine medication and psychotherapy. Would there be a role for this in ketamine? Dr. Prick, would you like to answer these questions?
Okay. In ketamine or esketamine? Esketamine, I presume.
They're asking about the psilocybin trial. They combine medication with psychotherapy. So in this case, I think the participant is asking whether there's a role of combination medication and psychotherapy.
Yes, there's always a role for combination therapies. Research has shown that when you combine psychotherapy with medication, you get faster relief and more prolonged symptom relief from depression. So I guess the best practice is always to combine these two modes of treatment that encompasses everything, which means modifying your dysfunctional thoughts, finding better ways of dealing with situation, coping strategies, exerting boundaries, things like that, together with medication. So medication works at a physiological level, I believe, and psychotherapy will work at a psychological level. So basically, you want to target everything to make sure that treatment is successful.
Just to add on the answer, I think just to let everyone know, even though you start the esketamine spray, the existing treatment must carry on. It's not a replacement treatment. It means that if you are on any antidepressant or even antipsychotic, when you need to start the esketamine, the existing treatment must carry on, not only the psychotherapy. So another question from Prof. Sagunan is how do you ensure compliance and adherence to correct technique? This one maybe I can answer on your behalf. So esketamine, you cannot bring home. You cannot take the spray and go home and spray. It must be under medical monitoring. So either you're inpatient, you can do it in the ward. If in clinic, we have a room where you can lie 45-degree flat with the BP monitoring and staff monitoring. You have the rest in the clinic for at least an hour before your blood pressure is stabilized, your dissociation is disappear, then you can go home. So it's treatment under direct observation. No bring home, no bring home. So you need to come twice a week if you're on the acute induction phase. You have to come twice a week to the clinic for the spray, so cannot bring home. So I think this answered the second question also. Does it need to be supervised? Yes, it need to be supervised. Is there any other questions? So it's available now in the hospital. Not commonly available in outside or in private setting. I think our hospital is one of the top user of this product. It help our patient a lot. It reduce admission, reduce unnecessary stay in the ward, and also won't burden our ECT services, because I think the ECT services in our ward is almost saturated. I think whoever from the NS department know about this. So with this new product, I think really can reduce the cost of the hospital, cost of the treatment, and help our patient to recover fast. So I think we almost come to the end. I would like to thank Dr. Preet for sharing with us today this interesting topic. And feel free to contact us if you still have any doubt or query about this product. With this, I will pass the floor back or pass to the next presenter. Thank you very much. See you, everyone. Bye.
Thank you. Bye.